Coming up next on Primary Care, Urinary Incontinence, or UI. Black women are less likely to develop it, but when they do, it's more severe.
Black women face different challenges related to other health issues that predispose them to incontinence. So I think we have more obesity in our community, and obesity is a risk factor.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. Urinary incontinence, or UI, isn't just one thing. It comes in different forms: stress, urgency, overflow, and functional. But no matter the type, it can really interfere with daily life. And UI doesn't affect all women the same way. Black women are less than half as likely as white women to develop it. But when they do, it tends to be more severe. Our guest today is Dr. Kandis Rivers, a top urologist at the Hennepin Health System. Dr. Rivers has years of experience helping women manage sensitive health issues with care and expertise. Kandis, welcome to the show. Thank you so much for joining us.
Thanks for having me.
Good. Tell us what this is all about. I mean, this urinary issue and the primary care side can give us nightmares sometime, and we're always referring to people like you. But what exactly is urinary incontinence?
So the medical definition is involuntary loss of urine. So meaning the patient has leakage of urine that is not related to their own volition. And it's very common. And when you were doing the intro, one thing that usually trips people up when we talk about the different types, we say stress incontinence, and they think emotional stress.
Right.
But when we say stress incontinence, what we're talking about is stressing the system, meaning jumping, laughing, coughing, sneezing. So stress incontinence is related to some type of physical movement. Urge incontinence is related to the desire to urinate and the inability to delay urination until you get to the bathroom. Functional incontinence is when they're basically someone who has decreased mobility, so they can't get to the bathroom fast enough because they have, difficulty with movement. They can't get out of bed or out of a chair. Stroke patients, wheelchair-bound patients, morbidly obese patients, with severe arthritis, they can't get to the bathroom in time. So they don't. If they were completely mobile, they probably wouldn't have incontinence. So those are the functional incontinence people.
So why does it seem to affect some women more than others?
Well, the reason why people get incontinence is multifactorial. There's a lot of organic reasons people get incontinence. The vast majority of women get incontinence as they age, related to the loss of estrogen. So the tissues in the urethra and the vagina become more atrophic, which means they become thinner, they're less, I say that it's just not as plump as it used to be. So it's like a washer that wears out, and so they start to leak. And that is directly related to age. So the older you are, the longer it's been since your last period, the lower your estrogen level, the more likely you're going to have stress incontinence. And what people don't know about urge incontinence is there are receptors for estrogen around the urethra, so you develop urgency and in the bladder. So the bladder has estrogen receptors, and the bladder becomes more fibrotic, less elastic. So when the bladder fills, it triggers the urge to urinate earlier than it used to. You used to be able to drink 3 cups of coffee and not have to go to the bathroom. Now you can't even have 1 cup of coffee before you're running 5 times to the bathroom because your bladder can't hold as much as it used to.
Would there be any particular type of incontinence that would predispose itself, or do we see a particular type of incontinence in the black population?
No, it's the same.
Across the board.
Across the board. I don't think black women have, a unique type of incontinence. I think black women face different challenges related to other health issues that predispose them to incontinence. So I think we have more obesity in our community, and obesity is a risk factor for incontinence. So and we have a higher prevalence of diabetes. Diabetes is a risk factor for incontinence. So I think it's just our comorbid conditions. I don't think there's something intrinsically about Black women that makes us have worse incontinence.
So we're getting a little age on us, and should we start looking for any early warning signs or symptoms that would say, boy, could I be developing incontinence outside of just the frequency of urination?
Well, I mean, I think women notice it and they ignore it a lot. They think, oh, it's par for the course. After I have a baby, I'm just going to leak. And that's not necessarily the case. I think you can have children and not leak. It does seem to be some genetic component. Your mom had it, and so you're more likely to have it. But if you're controlling for the things you can control, primarily your weight and your blood glucose, those are the two things that are within your control. I think this is somewhat controversial, but it's something I feel very strongly about, is that there's not enough estrogen being used in our community, and for women in general. And if you look at like a lot of studies, the studies that made us stop using estrogen came out when I was a resident, became a staff, so probably 20 years ago. And that study said that there was a 25% increase in breast cancer for patients who were on hormone replacement therapy. And this study was done first it was done in a group of nurses, and then it was broadened to a group of just women. But the problem with the study, there was a couple issues. The study was on women that were in their 60s and 70s. So they didn't have a lot of women who were in their late 40s, early 50s. So the morbidity of the estrogen replacement therapy was skewed because these women were already older, more likely to get strokes and heart attacks and breast cancer because of their age. The other thing was that the absolute number of women who actually got breast cancer it went from 1 in 1,000 to 2 in 1,000. So it doubled the rate of breast cancer, but the absolute number of cases was low. But the press took that and ran with it and said 50% increase in breast cancer, and that's when women were all taken off of their hormone replacement therapy. The risk of osteoporosis, of a lot of vaginal atrophy, genital urinary syndrome of menopause, urinary tract infections, and incontinence is really high if you don't have any estrogen on board.
Right.
And so judicious use in the right patient of hormone replacement therapy, or at least vaginal estrogen, can be a lifesaver for both urgency and stress incontinence.
I clearly recall how women were frightened about that portrayal of data through the media. That was devastating in some families.
But you see now, the hospital is full of women with broken hips. It's full. The morbidity of broken hip is, if you fall and break your hip in your 70s, 80s, and above, it's at least a 50%, if not 75% mortality. It's very, very high. And nobody talks about the flip side.
Plus the incidence of having another life-changing event.
Exactly. So I think we need to really look at that. And you'll see, in social media, there's a whole movement for, women entering menopause, because the benefit is in that first decade of menopause, 50 to 60. That if you do the hormone replacement therapy, your bones, your vaginal health, decreased recurrent urinary tract infections, and then there's some debate about whether you continue it after 60, 65. But for the women who stayed on it, they don't want to stop it because they feel so much better on it.
I have patients who will fight me for it.
They'll fight you for it. So I think that when a patient comes in and I talk to them, because of the media, their portrayal of hormone replacement therapy, women are just they don't want to even hear it. So usually I can convince them to at least try vaginal estrogen, which it works miracles, honestly, in a lot of patients.
So how soon should a lady be seeing her doctor with this issue? Should it be their call, basically, oh, I do have a few little symptoms? Should they not ignore those symptoms early on, or wait until they get worse?
So there is a menopausal society, and there are physicians who've gone through the training to talk to women about their journey through menopause. And those physicians can really help patients figure out how they want to proceed. So the average age of onset is 51. So, but it's obviously a wide variety. Some people start early and they're early to late 40s, all the way up to women who still are having their menses into almost 60. But whenever that time is happening, I think that they should have a consult about it. Personally, that's what I did. I went and had a consult and talked to somebody about it, so that what are my options, what should I be thinking about with my specific case, with my specific medical problems. Because, for instance, if you have hypertension and it's not well controlled, you don't want to give estrogen.
Exactly.
Or you want to get the hypertension under control first. If you have diabetes, you want to get your diabetes under control. If you're obese, you want to try to get your weight down. So every patient is different. It's not a, one size fits all.
So incontinence, as we look at it, is it a isolated situation, or could it be representative of other underlying medical conditions?
I think it can be isolated. There can be completely healthy women who
That's
just
the bottom line diagnosis.
That's it. And then there are women, you dip their urine, they've got some protein, they've got some glucose, their BMI is a little high, their hypertension's not treated well. So there are a myriad of presentations. But yes, I mean, I've seen 90-pound nuns who've never had a child, never had sex, who have severe incontinence. So it really is quite variable.
Do you run into any issues about females actually being embarrassed about this conversation in terms of bringing it up to their physician?
Not as much as you might think. I mean, I think women tend to talk about things. I mean, I treat men too, so I would say women talk about things more than men. I think women, though, are soldier on. I don't think they're afraid to talk about it. I just think they think that's just their plot in life and that they're just stuck.
So, a little bit on treatment, surgical versus non-surgical. Most people want to avoid a knife. So what do the options look like?
There's great options now. So there are injectables that you can do in the office. Bulkamid is the name of an injectable that's really become very popular because it lasts a long time. So with stress incontinence, so the kind when you jump, sneeze, laugh, cough, that type of incontinence is kind of graded 0, meaning the patient complains of it, but you can't reproduce it on any test or exam. Then there's type 1 and type 2 and type 3. For 0 to 2, I would try Bulkamid in a patient who doesn't want surgery. Now, many people say, well, I just want it fixed. The surgery has a 90+% success rate.
That high?
It's very high. So high volume surgeon who does these all the time, picks the right patient, they do great. And it's not mutually exclusive, so you can do the Bulkamid, and if it doesn't work, then just do the surgery. So that's the usual route most people will take. Well, let's try the Bulkamid, and then if that doesn't work, or if I'm leaking again in 6 months and I was really happy, maybe I'll just go ahead and do the surgery.
So patients who come in and say, look, I don't want to take medications, no more pills, and I'm afraid of surgery. What can I do naturally, holistic, or are there any exercises?
They get that question
in
all the
all
time.
disease states, I think we do, but are there any exercises that I can do that can get me out of this incontinence?
For stress incontinence, pelvic floor physical therapy is very, very helpful, especially for those lower grade, 1 pad a day or 1 or 2 mini pads a day. If you're soaking 5 pads a day, probably this physical therapy is not going to help completely resolve the problem. It'll help, but it probably won't completely reverse the condition. But somebody who's, willing to put in the work, go see a physical therapist, they teach you the exercises, and then you do them at home too.
Kandis, we are faced with questions about how does having babies affect my bladder and going through this thing in terms of evaluating incontinence. Women ask that question all the time.
More specifically, the women who have just had the baby, or like years later?
Years later.
Okay. Right. So birth trauma is a risk factor. So the size of the baby. So I always ask that question: how many children did you have? How many times have you been pregnant? And how big was your largest baby? And how were they delivered? So C-section versus vaginal. So all of those things have an impact. So if you have a 9-pound baby vaginally, then you're going to have a higher risk of incontinence than if you had a 6-pound baby by C-section.
A lot of women like to play games with it and say, oh, there's a 3-baby bladder, there's a 5-baby bladder. Is there any correlation between the number of deliveries at all?
Yes, yes. The number
The
of
more, the worse.
the more it is, the more worse it is, and the larger, and the size usually goes up. The more children you have, the baby just tends to get bigger because your pelvis can accommodate larger and larger size over time. So, yeah, then, so it's directly correlated to number of children, number of pregnancies, number of vaginal deliveries, and size of the baby.
Okay. Separate out overactive bladder, UTIs, and genital urinary syndrome and menopause.
So that is a kind of pet project or something that I'm very interested in because we see this all the time. And it's so interesting that they don't realize that all of their symptoms are related to the loss of estrogen. So you can have all of the things. You can have vaginal atrophy, painful intercourse, vaginal dryness by itself, not related to intercourse, urinary tract infections, and dysuria, which is burning with urination. All of those can be caused by genital urinary syndrome of menopause, meaning the changes that happen in the vagina and the urethra as relates to low estrogen.
So should we be telling women to avoid certain things that are common in our day-to-day travels in terms of what kind of foods to avoid, what kind of drinks to avoid?
I tend to start people on like a lower caffeine diet, try to avoid a lot of caffeine, especially towards the evening. Like if you got to have a cup of coffee in the morning, fine, but no more Coke or Pepsi or tea or coffee after lunch to try to decrease the amount of times you get up at night. I tell men and women that. But for genital urinary syndrome of menopause, that's where the vaginal estrogen comes in. And people get really frustrated because they have pain with urination and they keep going to the doctor thinking they have a urinary tract infection, and they don't. They just have the burning and pain all the time. Those are the women that really need to start on hormone replacement therapy plus estrogen, or vaginally, or if I can't convince them to take oral or patch, then at least vaginally, topically.
From the surgical standpoint of view, is there a use or an application of any type of laser form of therapy for this?
It's really popular in the lay press, like vaginal rejuvenation and that stuff. I mean, I don't think the data is really strong for it. I think I'm more about like prevention. And trying to get women in their late 40s, early 50s to start thinking about it. For the women in their 60s and 70s, it's still not too late. They still get a profound improvement. Sometimes you have to add an anticholinergic or some type of overactive bladder type medicine if they have those symptoms. But it's kind of miraculous sometimes when you put the vaginal estrogen with those medicines, how much improvement in incontinence and quality of life they get.
Sometimes the primary care for doctor is causing or adding to this condition. I mean, we're treating other conditions with medications that can actually cause some of these symptoms, especially in the diabetes world and the high blood pressure world.
Right.
How does that affect the overall outcome of these patients, especially when they need these other medications?
Well, I always tell them, let's talk to the primary care doctor about what options we have for your antihypertensive, for instance. Maybe we can get rid of the diuretic and switch you to something else that doesn't have so much of a diuretic effect. But I always say, your hypertension could kill you, right? Your incontinence is not going to kill you. So we have to figure out how to improve your quality of life while decreasing your risk of stroke and heart attack at the same time. And I think we have the technology to totally do that. It's not impossible.
So overweight patients seem to have more of a exacerbation with this problem. And getting people to lose weight, there are all kind of various options and challenges associated with it, but it seems to me that at the average female that could adjust a 5 or 7% of her weight overall over a period of time seems to have some improvement in these symptoms.
Well, they did these studies in the bariatric world. When bariatric surgery first came out, one of the side effects in some of the papers you'll see is that their incontinence went away. When they had these profound weight loss, they also didn't have incontinence anymore. So we've known for a long time that the higher the weight, the more incontinence, and so with the technology of all the new, GLP-1, GLP-2 medicines, I mean, I personally have prescribed those for people that I really think their incontinence is related to their obesity. If they're a candidate for it because of, hypertension and the obesity, the BMI is high enough, I don't think I try to get people to try it because losing 10% of your body weight could effectively, just eradicate the problem that you came to see me for. So,
if being overweight is the problem and a drug that causes weight loss is available, why wouldn't it be used in a situation like this?
Exactly. And I mean, I think I'm not someone that thinks that everybody should be on it, but when I'm looking at the whole patient, they've got diabetes, they've got hypertension, they've got incontinence, they're short of breath, they're so, have so many of the side effects of obesity, and one medication could potentially eradicate a lot of those problems. I suggest that they talk to their primary care doctor about it, and I will prescribe it for people too. I have prescribed it for people too, men and women.
Research-wise, clinical trials, we still are faced with the challenge of recruiting to the study activity in terms of African Americans across the board. I have a friend in Ann Arbor who is challenged right now because a research grant is probably not going to be funded to the same level simply because of the inability to recruit certain minorities to the study. What are we seeing in terms of that arena? We know we all face the same challenges in terms of clinical trials with African Americans, but are we doing better in this particular disease state? Can we expect some real changes down the road?
I don't know. I think COVID showed us there's a lot of hesitancy still in our community.
Yes.
I think that we need more Black researchers, and I think that the powers that have control over that, the federal funding that's available for that, really needs to be pushed to fund even smaller Black primary investigators. I think the military, because it isn't an equal opportunity, equity of access, has given us a lot of good data about, for prostate cancer, for instance, it's given us a lot of good data because, people in the military have equal access to health care as opposed to in the private world. But in the private world or outside or in the university setting, that's not the case. And there is, we just, at Henry Ford, we saw a lot of that where we could not convince people to be in our studies during COVID, for instance. People just wouldn't do it.
Dr. Rivers, you've been doing this for a little bit now.
Yes.
Tell me, how did your journey develop? In particular, how did you get an interest in being a urologist? Because I know maybe 6 African American urologists in the country.
It is. It was an interesting thing. So I was at University of Michigan, Ann Arbor for medical school, and I thought I wanted to be a thoracic surgeon. That was what I thought I wanted to do. But you don't declare right away, right? So I was on my surgical rotations. I was definitely sure I wanted to be a surgeon. And then I was rotating with a Black woman, Cheryl Lee.
Yes.
And she was a general surgery resident a year ahead of me. And Cheryl wanted to be a urologist. And I said, well, why would you want to do that? She said, oh, it's a great specialty. You should try it. I'm like, she's out of her mind. Why would you want to do that? But she convinced me to do the rotation. And when I did, I just fell in love with it. And Cheryl is the first Black woman chief of urology in the country. She's the chief at Ohio State now. And so really, Dr. McGuire, who was a white man, but he had, I don't know, a love for Black women, or he really recruited more women of all colors than any urologist at the time in the 80s when I was training, 80s, early 90s. And like the first Black woman urologist is from the University of Michigan. So I think I just happened to be in the right place at the right time, where there were Black women training in urology. There were none anywhere else, probably except Howard, maybe.
So that led to a dynamic career, a dynamic practice, and dynamic everything in terms of of what has happened over the last 20 years
Yes,
or so. Right?
yes.
Very
Just
good.
right place, right time.
There you go.
Yes.
Any research that we should be aware of that's coming down the pike? Any futuristic Star Wars stuff that's about to happen in terms of urinary incontinence?
Well, I think that one thing that there's some drugs that have come out that are really super helpful for urinary incontinence. The mainstay of treatment for overactive bladder, which is when I have the urge to go, I can't make it in time, those medications have traditionally had a lot of side effects. They're in the category of anticholinergics, so they cause dry mouth, constipation, and in older patients can cause some confusion. The new drugs are Myrbetriq, and now there's a second generation of Myrbetriq that are through a different mechanism, through the beta agonist mechanism. So they are medications that don't act through the cholinergic pathway, and they don't have any of those side effects. Of course, they're expensive.
Right.
That's the problem.
Not covered by insurance, probably.
Right, or you have to fight with the insurance company to get them. But they're great. So I generally will write 2 prescriptions in the office. I give the patient both and tell them to take them to the pharmacist and see what happens. Because I can't always tell what's going to be covered, but I tell them the reasoning for why I'm giving them what I'm giving them, and we do our best to try to get them.
Do you find that is becoming less of a barrier in terms of patients accessing the system and getting what they need in terms of medications?
Yeah, there's a lot of good things out there. There's GoodRx.
Right.
Mark Cuban has a website
Right.
For low-cost medication. Costco drugs are pretty cheap. Myers has free antibiotics.
Right.
So, you know, after you've been around for a while, you kind of just figure out how to work it, you know, to get people what they need.
Right. Kandis, this has been outstanding. Thank you so much for coming on the
You're
show.
welcome.
We'll do it again.
Yes.
Our guest today has been Dr. Kandis Rivers, a urologist at Henry Ford Health System. Urinary incontinence is treatable. Don't wait to talk to your doctor. There are real solutions for what is a real problem. That all starts with a conversation. For Primary Care, I'm Dr. Lonnie Joe.